Welcome to this video. We're going to be thinking about blood pressure. Blood pressure comes into nursing almost every day. We spend an awful lot of time, as you know if you've got any clinical nursing practice, taking blood pressure. So in this video I want to look at normal blood pressure and then go on and look at hypertension, high blood pressure. But first of all, let's start by thinking about the normal physiology of blood pressure. And I want to start off just by introducing a few ideas about blood pressure. So what do we mean by the term blood pressure? What does it mean? Well, blood pressure is simply the pressure of the blood, or the pressure that the blood exerts on the vessel walls that contain the blood. So blood is normally travels in blood vessels, arteries or veins, and the amount of pressure that the blood is exerting on those vessel walls is blood pressure. So that is all we mean. The pressure of the blood on the vessel walls in which the blood is contained. Blood pressure. Now, when we're talking about blood pressure, we're normally referring to the pressure in the arteries of the body. That is, in the systemic arterial system. So when someone says, go and take the patient's blood pressure, what they actually mean is go and record the pressure in their systemic arterial system. As we'll see in a minute, there are other types of blood pressure, but blood pressure normally means systemic arterial blood pressure. And we measure this in millimeters of mercury. Often written mm for millimeters, and Hg is the chemical symbol for mercury. So blood pressure is measured in millimeters of mercury. Now the next thing I want to think about is, why do we need a blood pressure? What is the point of having a blood pressure? Well, arterial blood pressure is necessary to push the blood through the tissues. If there's no pressure in the arterial system, there's nothing pushing the blood through the arterial system, into the smaller arteries, the arterioles, and then finally into the capillaries. So all tissues need to be perfused if they're going to be viable. They need blood flowing through them. And blood pressure is necessary to ensure tissue perfusion. And clinically, there's plenty of examples of this. If your brain is not perfused, well, you'll fall over. The reason I'm able to stand up now is because the blood is going from my heart down here and it's being pumped up to my brain. It's uphill. And my brain can't work without a regular supply of blood and a regular supply of oxygen. So you can tell at the moment my brain is being perfused because hopefully it is working. Blood pressure is needed to perfuse the myocardium. The actual heart muscle itself needs a constant supply of blood. It's got a very high oxygen demand and it needs a constant blood supply to supply that oxygen to it. The liver is always carrying out metabolic processes and it needs a blood supply to carry out those metabolic processes, both to supply the oxygen that it needs and to supply the energy required for that metabolism. The kidneys need a constant blood supply because they need the blood to filter to produce the urine. And in fact, to produce the urine, you need quite a good pressure of blood going into the kidneys. So normal blood pressure is required to achieve tissue perfusion. Absolutely vital to life. Now, blood pressure does vary a little with age. For example, at 2 years of age, then a systolic blood pressure of about 95 millimeters of mercury would be acceptable. So children have somewhat lower blood pressures than adults. Now don't worry about that term I've just used, systolic. We're going to come on to that in a minute. So a 2-year-old might have a systolic blood pressure of, say, 95 millimeters of mercury. But once children reach, let's say, about 14 years, then we can just use normal adult values for blood pressure. So 14 or 15-year-old young person, normal adult values would apply to that. Now, blood pressure is measured relative to atmospheric pressure. Now, when we measure blood pressure, suppose we find it's 120 millimeters of mercury, that actually means it's 120 millimeters of mercury above normal atmospheric pressure or above normal barometric pressure. So you may know that the pressure in the atmosphere is about 760 millimeters of mercury, normal atmospheric pressure, and then the blood pressure, systolic blood pressure, say 120. So that would actually give us a total pressure of 880 millimeters of mercury total pressure. But the only bit we actually take account of is the figure which the blood pressure is above the normal atmospheric or the normal barometric pressure. So when we're talking about blood pressure, we're actually talking about the degree to which the blood pressure is higher than the normal atmospheric pressure. In other words, it's not measured relative to a vacuum. The blood pressure is measured relative to normal atmospheric pressure. Another point, if we want to get a good idea of what someone's blood pressure is, we have to take the blood pressure several times. So when you want to know blood pressure, it's no good just taking it once. You need to take it several times. So you'd only diagnose someone as being hypertensive if you'd taken the blood pressure on several different occasions, preferably in several different circumstances. So one individual reading of blood pressure is less important than looking at a trend of readings of blood pressures. For example, if you went to a patient and found their blood pressure was 120/80, then a few minutes later the blood pressure had dropped to say 120/70, then 110/60, and then down to 100/60 or something like that. Can you see there's a trend that the blood pressure is going down? Now, if a patient's blood pressure was going down every time you measured it, what might that mean? Well, this is something all nurses need to know about, because if a trend for a blood pressure is to go down, it may be that the patient is going into shock, and that's very important to diagnose so that it can be corrected. So individual blood pressure readings are interesting, but trends are maybe more important. Short-term trends in the acute hospital situation, when we're checking to see if a patient is going into shock, and maybe a blood pressure recording taken on several different days if we're trying to diagnose whether a patient is hypertensive with high blood pressure or not. Now, two classic terms here, systolic and diastolic, absolute basic to understanding blood pressure. Systolic blood pressure is the pressure in the arterial system when the ventricle of the heart or the ventricles of the heart are actually contracting. So when the ventricles of the heart are actually contracting, pushing out the blood, generating the blood pressure, the pressure in the arterial system will be higher. And that is the systolic blood pressure. So when you take a blood pressure, you get two readings, a higher reading and a lower reading. The higher reading is the systolic pressure, and it represents cardiac contraction. It is when the heart is actually in the act of contracting. That is when the ventricles are actually contracting, pushing the blood out of the heart. The second reading is the diastolic reading. Now, the diastolic blood pressure is the pressure in the arterial system when the heart is relaxing. And of course it's lower than the systolic reading because the heart is not actually contracting. But the blood pressure is actually maintained fairly well, because when the heart beats, when it contracts, the blood's pumped into the arterial system and the arteries will expand. The pressure will widen the arteries. But the arterial system is very elastic, and then when the heart is relaxing and the pressure is lower, then the arteries will recoil. There's an elastic recoil. And that elastic recoil is pressing on the blood which is left in the arterial system. And that maintains a diastolic blood pressure. So the systolic blood pressure is the pressure when the heart is actually contracting. The diastolic pressure is the pressure in the arterial system when the heart is in its resting phase. So the systolic and the diastolic blood pressure. Now, I mentioned that when we're talking about blood pressure, we mean normally the pressure in the arterial system, in the systemic arterial system. But there's a few other blood pressures I'm just going to mention now to save confusion. So systemic blood pressure, normally about 120 over 80 millimeters of mercury, the pressure in an adult systemic arterial system. Now, do you remember that the aorta leaves the left side of the heart and supplies all the arteries of the body? Now, what is the artery that leaves the right ventricle of the heart? Well, the artery that leaves the right ventricle of the heart is the pulmonary artery, and it perfuses the lungs. It perfuses the lungs. And my heart is here, and my lungs are here. So really it's not that far to go, is it? Fairly short distance. So the pressure needed to perfuse the lungs is less than the pressure needed to perfuse my head and my feet all at the same time. So pulmonary blood pressure is going to be lower than systemic blood pressure. This is generated by the left side of the heart. This is generated by the right side of the heart. So something like 25 over 8 millimeters of mercury might be a normal pulmonary arterial blood pressure. Now, there's a pressure in the veins as well. And the pressure in the veins varies a lot, depending on what you're doing and what part of the body you're looking at. If there's a lot of blood pooling in the bottom of your legs, it could be quite high. Other times, the venous blood pressure is going to be essentially zero. But let's just take an example. Say one of the veins in the top of the arm. The blood pressure there would normally be something like, let's say 6 to 8 millimeters of mercury as a reasonable blood pressure in a largish vein. So the pressure in the systemic arterial system generated by the left ventricle, the pressure in the pulmonary arterial system generated by the right ventricle, and the venous blood pressure 6 to 8 millimeters of mercury generated by the mechanisms of venous return, such as adjacent muscle contraction, adjacent arterial contraction, and negative pressure set up during ventilation of the lungs. And the final one I'm going to mention in this section, capillary blood pressure. Well, capillary blood pressure is the pressure of the blood in the capillaries. Now, at the arterial end of the capillary, the pressure might be, say, 32 millimeters of mercury, and that probably drops down to around about 12 millimeters of mercury at the venous end of the capillary. So the pressure in the capillaries lower than in the arteries, but somewhat higher than in the venous system. And we're going to look at the factors that determine blood pressure. And I want to write down a couple of equations to start off our thinking about this. Now, blood pressure equals cardiac output times multiplied by peripheral resistance. So the blood pressure is equal to the cardiac output times the peripheral resistance. The cardiac output Cardiac output is itself equal to heart rate multiplied by the stroke volume. Now let's think about what these terms mean. Blood pressure equals cardiac output times peripheral resistance. So let's start with the cardiac output to decide what cardiac output means. Now, cardiac output is actually a volume of blood pumped out by the heart per minute, pumped out by the left ventricle per minute in this case. So cardiac output equals heart rate. So let's say a normal heart rate is 70 beats per minute. So the heart is beating 70 times per minute. And let's assume that the stroke volume is, say, also 70 mils. So 70 times a minute, the heart is beating out 70 mils of blood, which would equal 4,900 mils a minute. In other words, round about 5 litres. So cardiac output is heart rate times stroke volume, the number of times the heart is beating per minute or contracting per minute, multiplied by the volume of blood ejected every time the heart contracts, the stroke volume. So cardiac output is a figure, so many litres of blood per minute, and a cardiac output of, say, 5 litres of blood per minute would be normal when a person is reasonably at rest. So the blood pressure itself equals this amount of blood pumped out per minute, the cardiac output. But the other main thing affecting blood pressure is the peripheral resistance. Now, if the peripheral resistance increases because there's a peripheral vasoconstriction, because the blood vessels get smaller, then the blood pressure will go up, because when the vessels get smaller, when the arterial vessels get smaller, the peripheral resistance will increase. However, if the peripheral arterial system, and we're primarily talking about the arterioles here, if the arterioles dilate, get wider, then the peripheral resistance will fall and the blood pressure will also fall. So blood pressure is equal to cardiac output times peripheral resistance, and cardiac output is itself determined by heart rate times stroke volume. I think I'll just mention one other thing here. Blood viscosity. It's not normally a factor, but it can come into play. Now, if blood viscosity increases, then blood pressure will also increase. This doesn't happen very often, but sometimes a patient produces too many red blood cells, a condition called polycythemia, and that can raise the blood pressure. So more viscous blood will be at a higher pressure. Alternatively, if the patient drinks an awful lot, or they're infused with normal saline, for example, and the blood viscosity drops, then blood pressure will also drop. So blood viscosity can also affect blood pressure. But basically, the one to memorize is blood pressure equals cardiac output times peripheral resistance, and cardiac output equals heart rate times stroke volume. Now, just before we go on, let's have a short illustration. Now, we can illustrate the effects of cardiac output and resistance, peripheral resistance, just with an ordinary tap. It's an analogy. So there's the tap working now. Now, if I increase the flow rate of water by turning up the tap, that is, if I increase the cardiac output, the amount of blood that's being pumped out by the heart, then that's the same as increasing the flow rate. And if we increase the flow rate, well, we're going to increase the pressure. So there we have a low cardiac output with a low pressure, higher cardiac output, well, we have a higher we have a higher blood pressure. So an increase in cardiac output will increase the blood pressure. But the same is true with peripheral resistance, with resistance to the flow. So there's a fixed cardiac output. A particular volume of blood is being pumped out by the heart every minute. And if I reduce the lumen that the water's coming out of by pressing over the end of the tap, I think you can see there that because the water's coming out of a smaller lumen, I've essentially increased the resistance and we get an increase in the pressure. So the pressure of the water there is greater than the pressure of the water there. So increased cardiac output will increase blood pressure, decreased cardiac output will decrease blood pressure. No peripheral or little peripheral resistance there, the blood pressure will be low. But if we increase peripheral resistance, well, we can increase blood pressure. I want to consider is the normal control of blood pressure. Now, blood pressure is one of the many parameters in the body which must be homeostatically controlled. If it goes too high, then we become hypertensive. If it goes too low, then we become hypotensive. Both are pathological. We need the blood pressure to remain at a constant normal rate. We need to be normotensive. Actually, it's not quite constant because it varies depending on what we're doing. But if the blood pressure goes too high, we're hypertensive. If it's too low, we're hypotensive. So we need a homeostatic regulation of blood pressure. And I'm going to consider this under two headings. The first is neuronal control, under the control of the nervous system. And the second is endocrine control, under the control of the endocrine system. So first of all, let's start off by thinking about neuronal control of blood pressure. And I'm going to start off just by pointing out a few areas of anatomy. Now, the first area I want to point out is the aortic arch, the arch of the aorta. Here's where the aorta leaves the left ventricle, and here's the aortic arch. Actually, it goes back a bit, we can't really see it in this model. So the aortic arch is the first area of anatomy to point out. Now, the next area I want to point out is called the carotid sinus. Now, this is the common carotid artery here, running up the neck, and it bifurcates here into the internal and external carotid artery. Now, the carotid sinus is just at the bifurcation of the two arteries just here. So the carotid sinus at the bifurcation of the carotid artery. Now, the third area I want to look at is in the brain, and we'll look at a cross section of the brain. Here we see the cerebrum, the cerebellum, and the brain stem. Remember, the brain stem is basically in three parts, three areas: the midbrain at the top, the pons in the middle, and the medulla is in the bottom part. And the area I particularly want to point out is the medulla and the bottom third of the pons, this area of the brainstem here, because this contains the area we're going to be looking at called the vasomotor center. Let's try and draw a diagram now of what's going on. So here we have the arch of the aorta and the carotid arteries which leave the aorta. And we've already said that we haven't actually said but we'll say so now, there's pressure receptors in the arch of the aorta. Now, these pressure receptors respond to stretch, and they're called baroreceptors. Baro means pressure. So there's baroreceptors in the arch of the aorta, in the wall of the aorta, which are detecting blood pressure. Then further up when the carotid arteries bifurcate in the area of the carotid sinus. There's more pressure receptors here. And again, they respond to blood pressure. They're stretch receptors and they detect the pressure of the blood in the carotid arteries. So the aortic arch baroreceptors are detecting the pressure of the blood in the aorta, and the carotid sinus baroreceptors are detecting the pressure of the blood in the carotid arteries. Now further up here we've got the brainstem. There's the brain on top of it and the cerebellum behind. Now there needs to be connections between these baroreceptors and the part of the brain stem. Now from the aorta, nerve fibres come together to form a branch of the vagus nerve, and this goes up and feeds into these branches go up and feed into the medulla. So the pressure is detected by the baroreceptors in the aortic arch, and these send impulses up the vagus nerves into the medulla. The baroreceptors in the carotid arteries, they form branches of another nerve that goes up and joins in to the brainstem as well. So the nerve that connects the baroreceptors in the aortic arch up to the brainstem is the vagus nerve. Branches of the vagus nerve going from here, from the baroreceptors in the aortic arch up to the brainstem, the vagus, and from the carotid sinus up to the brainstem, these are branches of the glossopharyngeal nerve. Glossopharyngeal nerve. Now, the vasomotor centre is a network of neurons related in the bottom, found in the bottom third of the pons and in the brainstem. And the vasomotor centre, via the spinal cord, sends impulses out to the peripheral blood vessels. So impulses from the vasomotor centre will constrict peripheral blood vessels. They'll make them go smaller. They'll cause a vasoconstriction. Now, the blood vessels, the arterioles, if they're left to their own accord, they'll dilate, they'll get wider. But when there's an impulse, a sympathetic nerve impulse from the vasomotor centre, that causes them to constrict. And if the blood vessels constrict, the peripheral blood vessels constrict, what will that do to blood pressure? Well, if the peripheral arterioles constrict, that will increase blood pressure. So the vasomotor centre will cause peripheral arterial vasoconstriction. As well as that, impulses from the vasomotor centre will constrict the peripheral veins as well. It'll cause a peripheral venoconstriction. Now, if you get a peripheral venoconstriction, that's going to increase the pressure in the veins, and that will increase the venous return to the heart. There'll be more blood going back to the heart because the veins have constricted. And if there's more blood going back to the heart, that means more blood can be pumped out from the heart, so that will also increase blood pressure. In addition, impulses from the vasomotor centre will act on the heart to increase heart rate and stroke volume. So you can see the more impulses coming from the vasomotor centre, the higher blood pressure is going to be. Impulses from the vasomotor centre will peripherally vasoconstrict arterioles, peripherally vasoconstrict veins. You'll get an arterial vasoconstriction and you'll get a venous vasoconstriction. You'll also get increased cardiac output via the mechanisms of increased heart rate and increased stroke volume. Now, all the time there's pressure in the aorta and the carotid arteries, there's going to be impulses going up the vagus nerve and up the glossopharyngeal nerve towards the vasomotor center. And the higher the blood pressure, the more nervous impulses are going to go from the baroreceptors to the brainstem. So when the blood pressure is high, there's going to be a lot of impulses going up to the brainstem. When the blood pressure is low, there's less impulses go from the baroreceptors to the brainstem. Now, when the blood pressure is high and there's a lot of impulses going to the brainstem, then these impulses from the baroreceptors inhibit the sympathetic outflow from the brainstem. So the higher the pressure, the more impulses going up to the brainstem via the vagus and glossopharyngeal nerve, the less impulses leaving the brainstem to bring blood pressure up. And that makes sense. If the blood pressure is already high, you don't want it to go higher. However, if the blood pressure drops, then there's going to be less impulses going up the vagus nerve, less impulses going up the glossopharyngeal nerve from the baroreceptors. And if there's less impulses from the baroreceptors going into the brainstem will automatically increase its sympathetic outflow to vasoconstrict arteries and veins and increase cardiac output, so restore blood pressure. So let's just review what's going on here. Blood pressure is detected in the aorta and carotid arteries, detected by the baroreceptors. When the pressure is high, impulses travel in the baroreceptors to the brainstem, which inhibits the outflow of the brainstem. However, if the blood pressure drops, less impulses travel up the nerves to the brainstem, so there is less inhibition of the vasomotor center by baroreceptor impulses. Therefore, there will be an increased sympathetic outflow from the brainstem to raise blood pressure. Just before we leave this section on the vasomotor center, I want to mention 3 other factors which can influence its activity. Now, the first one I want to mention is influence from the higher centers. Now, what we mean by this is influence on the vasomotor center from higher centers in the brain, from the cerebrum, from the areas of consciousness. So, for example, if someone's under stress or angry, this will tend to increase the activity of the vasomotor center, therefore increase blood pressure. Or if someone's anxious, you know, when you're anxious, your heart's beating fast, you can feel your heart beating. These are effects of the vasomotor center increasing blood pressure when you are anxious. So those higher effects can raise blood pressure, but higher effects can also lower blood pressure. If you get an emotional shock, if something really upsets you that you see in the environment round about you, then that can cause an individual to faint. And a faint is caused by an acute cerebral hypoperfusion, an acute reduced blood perfusion of the brain, and that will cause the individual to faint. It's nothing to worry about as long as you lie them down and let them come around gradually, then just carry on with whatever you are doing. The key thing with fainting is not to get anxious and get a complex about it, because it passes off with time. But it's important to notice that effects of the higher center can either increase or reduce blood pressure. Now, the next one I want to mention is clinically quite important. When the levels of oxygen in the blood start to drop, if a patient is becoming hypoxic, then this will stimulate the activity of the vasomotor centre to increase blood pressure. The heart will go faster and the blood will be going around the body much more quickly. Now the reason for this, if you think about it, is to try and compensate for the hypoxia. It's a compensatory mechanism, because remember, it's the oxygen that carries the blood round about the body. And if there's not enough oxygen in the tissues of the body, one way to compensate for that is to have more blood going around the tissues to try and carry more oxygen to those tissues. So in the early stages of hypoxia, it's normal to get an increased heart rate and increased blood pressure. The last one I want to mention is reduced levels of carbon dioxide. When the levels of carbon dioxide in the blood are low, this will do the opposite. It will reduce the activity of the vasomotor centre, and therefore blood pressure will be lowered. So low levels of oxygen can increase blood pressure. Low levels of carbon dioxide can reduce blood pressure. So remember, higher influences, low levels of oxygen, low levels of carbon dioxide, again can all have influences on the vasomotor centre and therefore on blood pressure. Now remember, we're still thinking about normal blood pressure, and we've looked at neuronal control, the influence of the nervous system. The next area of control of normal blood pressure I want to look at are endocrine factors, hormonal factors. And the first one I want to talk about is the renin-angiotensin mechanism. Now this all begins when there's a reduced blood flow to the kidney. So if the blood pressure in the kidney drops, that's where this story starts. So we'll start off with a renal hypoperfusion. If for any reason the blood supply to the kidney is reduced. So if there's a drop in blood pressure, the pressure of the blood entering the kidney will be reduced. So here's the kidney, and it can detect reduced blood pressure entering the kidney. Now this is actually detected, as far as I understand it, in the juxtaglomerular cells in the afferent arteriole. So the afferent arteriole on the kidney recognises that the blood pressure is being reduced. Now it's very important for the kidney to have a good blood pressure of blood going into it, because the blood pressure is necessary to facilitate the process of glomerular filtration, which is essential to urine production. So the kidney, in a sense, is kind of looking after its own blood supply. So it detects if there's a renal hypoperfusion. And the juxtaglomerular cells in the walls of the afferent arterioles respond by releasing a hormone called renin. That is, they will release renin when the blood pressure to the kidney drops. So when there's a renal hypoperfusion, the kidney detects that and it produces renin. So the kidney produces renin, an endocrine hormone. Now, all the time in the plasma, there's a plasma protein. And the plasma protein is called angiotensinogen. So angiotensinogen is present in the blood. It's a plasma protein. And it's fairly inactive. It doesn't do very much. However, if angiotensinogen is converted into angiotensin, and in fact the type of angiotensin that angiotensinogen is converted into is called angiotensin 1, the first type of angiotensin. This is a protein, the angiotensinogen is a protein, Angiotensin is a peptide, it's a polypeptide. It's actually got 10 amino acid units in it. Now, angiotensin is produced when angiotensinogen is acted on by renin. So renin facilitates the conversion of inactive angiotensinogen into angiotensin 1. But actually, even angiotensin 1 is not that active a molecule. But angiotensin 1 can be converted into another molecule called angiotensin 2. Angiotensin type 2. Now, angiotensin 1 is converted into angiotensin 2 by an enzyme called angiotensin converting enzyme, ACE. Angiotensin converting enzyme. And this takes place as the blood passes through the lungs. The angiotensin converting enzyme is produced in the linings of the blood vessels in the lungs. Now, angiotensin converting enzyme acts on angiotensin 1 to facilitate its conversion to angiotensin type 2. You may have come across drugs called angiotensin converting enzyme inhibitors, ACE inhibitors. ACE inhibitors work by inhibiting the activity of the angiotensin converting enzyme. So let's review what's happened. The kidney is hypoperfused. That's detected. The kidney responds by producing renin. Renin facilitates the conversion of inactive angiotensinogen, a plasma protein, into angiotensin type 1. Now, angiotensin type 1 is mildly active, but angiotensin type 2 is much more active. Angiotensin type 2 is actually just a smaller peptide unit that actually contains 8 amino acids. Now, what does angiotensin type 2 do? Well, the first thing it does is it causes arterial vasoconstriction. Arterial vasoconstriction. If you vasoconstrict the arterioles, if they get smaller, you will increase peripheral resistance, and that will result in an increase in blood pressure, because blood pressure equals cardiac output times peripheral resistance. And angiotensin 2 is a very, very potent vasoconstrictor. It is a very effective vasoconstrictor, so it can raise blood pressure really quite a lot. Actually, as well as vasoconstricting the arterioles, angiotensin 2 will venoconstrict a little bit. If you get a venoconstriction, that increases the pressure in the veins of the body, and that increases the amount of blood which is going back to the heart. It improves venous return to the heart. If there's more blood going back to the heart has more blood to pump out. Therefore, it can increase cardiac output. But the main mechanism in terms of vasoconstriction is the arterioles. As well as that, angiotensin type 2 is a very, very powerful stimulator of thirst. The patient becomes very, very thirsty. You may have noticed this in patients that are shocked, that they can be incredibly thirsty. And normally it's good to give them water to drink. Normally. Unless they're being prepared for surgery. So it stimulates thirst. So the patient will drink, the water will be absorbed into the blood, this will increase intravascular volume, that will increase venous return. Venous return will allow an increase in cardiac output. So thirst is good because